Okay, last few videos have been kind of long, so I'm gonna try to make this one quick. First of all, shout out to Paulina for the entire study guide. It has literally everything. Some of them have more information than you need, so it's a good review as well to kind of explain the key concepts that she has in the study guide. The other thing I would say is also go over, whether you watch the 2 lectures or you just go over the 2 PowerPoints, because some of her study guide stuff are kind of vague. Like she'll just say like ureter, or she'll just say like urogenital diaphragm or something, but without like the specifics that she wants from each one. So I'll still go over it. I'll also do a lab video to kind of go over the 2 lab PowerPoints that she sent, just kind of like highlighting key things and skimming over it. So hopefully that'll be out by tonight. All right, so ureter is a retroperitoneal organ, which means that only anteriorly covered by peritoneum. So the back, the retro, like someone has like retrograde amnesia, they can't remember things from the past behind them, back. So only anterior is covered, not the posterior. It's behind the peritoneum, in other words. It goes from the renal pelvis to the urinary bladder. Now that kind of is nice because it already gives you 2 of the constrictions out of the 3. So the 3 constrictions for the ureter are where it starts, so the utero-pelvic junction, where the uterus comes off of the renal pelvis, so utero-pelvic junction. And then the 3rd constriction is the utero-vesical junction. Anytime you see vesicle, that means bladder. So where it connects to the bladder. So over here, this is your first one, the utero-pelvic, uterus or ureter to pelvis, renal pelvis. And then this bottom one is ureter to bladder or utero-vesical. The 3rd constriction is in the middle, and it's where the ureter crosses the bifurcation of the common iliac artery. So your aorta comes off your heart, so this is your heart, whatever, right atrium, right ventricle, left atrium, left ventricle. Off your left ventricle, this is your ascending aorta, ASC, and then it arches. This is your arch of aorta, and then it descends above your diaphragm. This descending aorta is also called thoracic aorta, and then below it's called abdominal aorta. So your abdominal aorta will then give you 2 common iliac arteries. So this is a right common iliac artery and a left common iliac artery. Anytime you see common, that means it's going to split. So this will then split into an internal and external. So this is your external iliac and this is your internal iliac. So where this splits right here on each side, that's where your middle constriction is. So right here. You can also see it right here. So this right here is the aorta. So it already gave off the common iliac, which you can see right here. And then it splits into external and internal. Internal iliac will go to your pelvis. External will go to like your thigh. It'll become your femoral artery, which goes like to your femur and like your lower extremity. So those are the 3 constrictions. The other thing about the ureter is it is a one-way valve, so it prevents backflow. And then it goes to the posterior wall of the urinary bladder. So that's where it attaches. I don't know if you can see it in here, but it's going to the back of the urinary bladder. And then kidney stones can get stuck in there, specifically at the constrictions. Okay, next, internal iliac and its branches. So we just talked about kind of like how the internal iliac comes off of the common iliac, which came off of your abdominal aorta. Now, we said the internal iliac is going to, so if I zoom this in right here, this is abdominal aorta, right common iliac, left common iliac, external iliac, internal iliac. Internal is going to do all of like the pelvis stuff, like your genital stuff. External is going to go down to your leg. So, internal iliac will have posterior and anterior divisions or branches. So this is how I remember them. There's a few of them. So the way I remember them is this. For the posterior branch, whatever letter ends the first one will start the other one, if that makes sense. So iliolumbar is IL. So then L will start the next one, which is lateral sacral, which is LS. And then S will start the next one, which is superior gluteal, or SG. So that's how I remember it. So if you look at your posterior branch, you have so these three right here are your posterior branch. This is internal iliac, anterior branch, posterior branches. So posterior branches are your first one that's ascending is your iliolumbar, your IL. Then you have your LS, so lateral sacral, and then finally you have your superior gluteal. Superior gluteal will go to the back and innervate like the glutes. That's your posterior division branches. Now, for the anterior division branches, there's a lot of them. She has a few that she highlighted. The umbilical, which really stops having like any function, and it will become the superior vesicle after like you give birth and everything, or after you're born. There's an inferior gluteal, an obturator, a middle rectal. So this is how I kind of remember them. And then the difference between the male and female ones. If you think about the pelvis, let's say in a female, for example, first thing you'll have most anteriorly is your bladder. Behind your bladder, you'll have the uterus in females, and then behind that, you'll have the rectum. So this also will tie into like the different pouches when you compare males and females. Males only have the bladder and rectum, so they'll only have one pouch called a rectovesical pouch. So I might as well go over this stuff. Rectovesical pouch. Whereas in females, the uterus splits them into two pouches. So this is recto uterine, because between recto and uterus, and then this one is vesico-uterine pouch, because it's between bladder and uterus. So two main pouches versus one main pouch. This one right here is called the pouch of Douglas, and it's important for like draining fluid and whatever, but that's for later. So the reason I kind of wanted to explain that is the way I remember the order of these arteries is it goes bladder, then uterus, then rectum. So if you're looking at your anterior branches, this one that doesn't even like have a function anymore was your umbilical one. But we don't care about that. The first one that you see here is your superior vesicle, which makes sense because this is anterior, this is posterior, and then this is lateral. It shows you lateral on the side, and then down would be inferior. So the most anterior is going to be the one that controls the bladder, which makes sense because that's your most anterior organ there. So you have your superior vesicle first. Then, with obturator and internal pudendal, they each have their own unique thing that like distinguishes them. Obturator artery immediately goes through this obturator foramen. So if you see an artery just going down medial deep into a foramen, it's the obturator artery. If you see a nerve there, it's the obturator nerve. So these and this, the internal pudendal artery, it looks like it's going to escape, but then it comes right back in. So it has like a unique route. It like goes out of the greater sciatic foramen, but then comes back to like the lesser sciatic foramen. So these two have like their own unique routes. But if you look at the other one, so there's this one, the superior vesicle. There's this one. And then there's these two on the side. So these are the main ones that we want to distinguish. So superior vesicle is going to be most anterior. Then after your obturator, you have either a vaginal or inferior vesicle, depending on the gender. So females will have a vaginal artery. Males don't have a vagina. So we will have another artery that hits the bladder. So it makes sense that this artery will be the next one because we just had an artery that hit the bladder, the superior vesicle. So if we're going to have another artery that also is going to innervate the bladder, it's the inferior vesicle. This also innervates the prostates in male. So it'll go superior vesicle and then obturated through the foramen, then inferior vesicle or vaginal. The next artery, if you're trying to remember if it's going to be the uterine artery or rectal artery, the next organ will be the uterus, and then the rectum. So this will come before this, if that makes sense. So the two bladder ones will come first. So if we're looking at males, just males, it'll be superior vesicle, then inferior vesicle. Then we don't have a uterus, so it'll be the ductus deferens, and then it will be the middle rectal. And then the one going here is your obturator. And then the one doing the little zigzag thing is your internal pudendal. And then the same way we said the inferior vesicle is going to be close to the superior vesicle. Remember, one of the posterior branches is the superior gluteal. The anterior branch gives the inferior gluteal. So this has to be the most posterior because it has to go right next to the superior gluteal to go and innervate your glutes. So this is how it'll be in males. In females, it'll go superior vesicle, then going down is obturator. After that, they don't have an inferior vesicle. Instead, they have the vaginal artery. Then it's the uterine artery. And then it's the middle rectal. And then we know the internal pudendal goes like this. And then inferior gluteal is at the end. So if you remember the order of bladder, uterus, rectum, then you'll remember in a female, it would have to go superior vesicle, uterus, middle rectal. You just have to distinguish between males and females, these two key ones right here. So males don't have a vagina or a uterus. So instead of the vaginal artery, we'll get another artery that supplies the bladder. And then instead of the uterine artery, we'll have the ductus deferens. So the way to remember these is Viv, you dangerous dog. Just imagine you have a dog that's always like running around and doing crazy shit. So Viv, V-I-V. So vaginal, inferior vesicle. And then U, dangerous dog. U is uterine artery. This is ductus deferens. And it works out nicely because it goes female, male, female, male. And that's the difference between them. These are also kind of nice grouped together because these will actually create your, I can't write, water under the bridge phenomenon or like image, which we'll go over later on. But I don't know if this makes sense. That's how I remember it. So for the posterior, it's the one that ends, the letter that ends will start the other one. So IL, LS, SG. And then for the anterior branches, if you go from anterior to posterior, you just follow the order of bladder, uterus, rectum in females. And then you take the counterparts in males. And then the two that have a unique sort of pathway are the obturator, which goes just medial straight down through the obturator foramen. Then the internal pudendal artery, which has like a wrap around it. It acts like it's going to go out, but then it comes back in. Okay. Now, lumbar plexus and the relationship to psoas major. All right, we're going to make this super easy. This big-ass muscle right here is your psoas major. If you think of the way the muscle is like angled, it like separates your genitals from your external or like femoral side, because eventually you're going to go down to your femur, which is your big thigh bone, and it's going to go down to your like lower extremity. So the nerve that literally sits on the psoas major or anterior to it is literally called genitofemoral. And then it also has a genital and a femoral branch, but we don't care about that. But it's called genitofemoral. So think of the way your psoas is shaped. It like separates your body into a genital and femoral side on each side. So the artery or nerve on it is the genitofemoral. The medial nerve right here going down into this obturator foramen. We just looked at the artery. This is the nerve. So medial to psoas major is going to be your obturator nerve. They also have, I don't know if this was talked about extensively in the PowerPoint, but she also has lumbosacral trunk. If you look over here, so this right here is your obturator nerve. It's one nerve. If you look over here, you have a bunch of nerves that go together, forming a trunk. That's technically your lumbosacral trunk. So I'll highlight that, but the other ones are the main ones. Usually she'll be like medial to it is obturator, anterior is genitofemoral, and then lateral is where you have a bunch of them. So lateral, you have your iliohypogastric, ilioinguinal, lateral, femoral, cutaneous or LFC, and then femoral. So if you start with your psoas major, the big-ass nerve going down into your thigh, remember, big thigh bone is femur. This right here is your femoral nerve. So lateral to it, that provides just skin sensation to the side, is going to be your lateral femoral cutaneous. Literally lateral to the femoral gives cutaneous or skin innervation. Now, if you look up here, you have this nerve root that splits these two. You can see it on both sides. Here, it splits these two. That nerve root is L1. And the way I remember it is, so iliohypogastric and ilioinguinal, ILI or IML1. These are both L1, and it branches off into giving you these two. To remember which one goes first, just remember high or H comes before I. So the top one will be your hypogastric, iliohypogastric. The lower one is your ilioinguinal. Now, this one is technically not a lumbar nerve. It's called subcostal. And if you think of the name subcostal, sub means like bottom. Costal is like your ribs. So we're thinking like thoracic range. So this is actually T12, but we use that nerve to kind of landmark that, okay, this has to be the subcostal, which means the next one's the iliohypogastric, next one's ilioinguinal, next one's lateral cutaneous, next one's femoral. Then you have your genitofemoral on the psoas major, and then medial to is going to be your obturator. And then if they ask about lumbosacral trunk. So on the psoas major, genitofemoral, medial to it is obturator, lateral goes high, and then lateral femorocutaneous and femoral. Anything else on here? No, I think that's what we already said. Split from L1, you get ilioinguinal hypogastric, femoral lateral, obturator medial. Also, for bony landmarks, your lateral femorocutaneous goes to your ASIS, or anterior superior iliac spine. You obviously would need a pelvis seat more clearly, but it goes to here, which is your ASIS, if they ask. Okay, now, pudendal nerve block. A pudendal nerve, it's a mixed nerve, so it'll do both sensation and motor. The sensation is specifically to the external genitalia, perineum. Motor are the sphincters. So it's either anal or urethral sphincter. This will help either hold in or avoid any urine, any stool, all that stuff. So this is from her slide. The key nerves are the inferior rectal nerve, which is this one right here. Your perineal nerve, this one right here, which breaks off into a muscular, which is these ones here. And then a superficial branch, which will go down. And then you'll have a posterior scrotal, which does sensation to the scrotum. And then the dorsal nerve of the penis or clitoris. So then that'll do skin sensation over there. So pudendal nerve has obviously a lot of important functions in the genital area. If you are going to have surgery in this area, or during childbirth, if they're going to stitch back up the tears in the vagina, you will need to block this nerve off, or else you're going to feel a lot of pain. So the way you block it off is right here. It says ischial spine is the bony landmark. For males, you'll go through the rectum because we don't have a vagina. And then for females, you'll go through the vagina. You will literally put your fingers in there to palpate this bony landmark. And then from there, the pudendal nerve is there. So that's where you'll inject it to block out the pain when you're doing surgery or you're stitching up the vagina after childbirth. And this is another example. Over here, you use that bony landmark, and that's where the nerve is going to run. You can see the nerve here run with all of its branches going around that supply all the different parts in there. And I think that covers everything on here. I don't know if she'll go into detail about what each nerve does, but you can kind of tell from the name. So the inferior rectal is going to do the rectum stuff. So going all the way down to the anus. So it'll do the skin there, and it'll innervate the sphincter. So sensation and muscle. And then the rest are kind of just self-explanatory based on the name. Okay. Prostatic cancer, BPH, or benign prostatic hypertrophy, and blood supply to the prostate. So we'll make this simple again. The prostate, first, is superior to the pelvic diaphragm. It's the largest accessory gland of the male reproductive system. It produces fluid that helps neutralize the acidity of the vagina. So when sperm is going into the vagina has a very acidic pH. So to protect it, the prostate produces fluid that can handle that and neutralize the acidity of the vagina. So it's obviously very important. It's split into 5 lobes. So you have an anterior, posterior, median. So anytime you see the word median, means literally middle. So if I have something in the middle, and I had like two nerves coming off like this, for example. This would be a medial, this would be a lateral, and then on each side. Medial means closer to the middle. But if something is just middle, we say median. The N just means there's one and it's in the middle. If that makes sense. So a median lobe is just one lobe in the middle. So in this case, there isn't even a medial. There's just a lateral. And then you have two lateral lobes. So if you're looking at it from a transverse section, you have your lateral lobes on the side, anterior on top, middle, and posterior. Now you can see it more clearly from a sagittal section. So the anterior lobe is in front of the urethra, which you can see right here, front of the urethra. Posterior lobe is not only posterior to the urethra, but it's also inferior to your ejaculatory duct. So posterior to urethra and inferior to the ejaculatory duct. And then median lobe will be posterior to urethra, but superior to your ejaculatory duct. So this right here is the key difference. Now, and the lateral lobes are just off to the side. The way to remember which one causes BPH, or benign prostate hypertrophy, and which one causes cancer, think of Ben trying on his medium shirt in the back closet. So BPH, or Ben, for benign prostatic hypertrophy, trying on his medium or median lobe shirt. So BPH is in the median lobe. Cancer, or the closet he's going to, is the back closet or the posterior closet in the store. So posterior causes cancer, median is where cancer usually goes to the posterior lobe, BPH is usually in the median lobe. Now, what's nice about cancer going to the posterior lobe mainly is that that's the most easily palpable or easiest part to touch and feel in a patient. So if you have the patient bend over, so you see the patient like bent over like this, and then you put two fingers in through the rectum, obviously this isn't a male because you're feeling for a prostate, you can push anteriorly and you can feel the prostate. This is most anterior, this is most posterior. So right here, what you're feeling is the posterior lobe. So if there's a cancer in there, you'll either feel, it could either be too big, it could feel weird, bumpy, or just has like a different feel. That could be a sign of cancer in the prostate. And I think that covers all this stuff. You can see it's also inferior to the bladder, and then anterior to the rectum in the picture. So bladder, prostate, rectum. So inferior to bladder and anterior to rectum. Okay, now the uterus. So now we're going to talk about females. She asks for the support for the uterus. There's two important supports. The most important is pelvic diaphragm. If she says most important support to the uterus, always pelvic diaphragm. The second support is your transverse cervical ligament, which is also called your cardinal ligament. So pelvic diaphragm will anchor it from the bottom, so it will give it the floor support. Your transverse cervical ligament will hold it to the lateral pelvic walls. Obviously, the one holding it down is more important, because what happens if you don't hold it properly is it can lead to prolapse. So usually a uterus is, I don't know why this is such a blurry picture, but this is bladder, uterus, rectum. The uterus is anteverted, so it's anteriorly towards the bladder. And usually the top part here is, you see how it's like, it doesn't go straight. It's like more flexed, so it's anti-flexed as well. So normal uterus is like anteverted, or I don't want to say normal, but like most of the time, that's how it is, and anti-flexed. What happens is if you lose the support, so this transverse cervical will hold it like laterally to the side from this side and the other side. The pelvic diaphragm will hold it to the bottom. So if there's damage there, the uterus will literally dip down. This is called prolapse. So uterus descends into the vagina. So that could be a problem if you don't have the proper support there. And then this is what a normal, or that's what an anteverted uterus looks like, which is in most cases. If it went back or away from the bladder, it would be retroverted. Retro means back. Okay. Now, for the uterus, you have a fundus, you have a body, and you have a cervix. So the fundus is the top part, body is the middle part, cervix is like the bottom part. Do I have a picture here? I do not have a picture here, but you can see the cervix being like the bottom part, opening into the vagina, and then top would be the body, then technically, or middle will be body, and then technically middle will be the fundus. But we'll see the stuff in like the lab part. So those are the three parts. Fundus, super important. That's where implantation happens. And then external os of the cervix. So we just saw the cervix going into the vagina. So it's specifically the external os that goes into the vagina. Now, you have three main ligaments. So the blood supply to the uterus, before that, mainly it's your uterine artery. Uterus, uterine artery, kind of self-explanatory. But there's also like anastomosis that happens with other arteries around. So your ovarian artery will anastomose and your vaginal artery and all that stuff. But main one's the uterine artery. You have a broad ligament that has three divisions. So you have a mesometrium, mesoalpinx, and mesovarium. Mesovar is ovary. So that's the one that connects to your ovary. So that one's like kind of easy to remember. And then you have mesoalpinx and mesometrium. So A is at the top of the alphabet. So that's the one that's going to be superior. So if you're looking at like a sagittal plane, this is your ovary. If we push it over to the side like this is what it'll look like. This is your ovary. The one connecting to your ovary is your mesoovarium. The superior part is your alpinx. Inferior is your mesometrium. So this entire thing here is mesometrium. This top part is alpinx. Then the ovarian is mesoovarian. There's another picture here. So this top part, all mesoalpinx. This bottom part would all be mesometrium. All of this orange stuff is your broad ligament. So that's three different parts. You also have a round ligament. So what's key about this is that it goes through the inguinal canal, terminates in the labia majora on the vagina, supports the uterus, whatever. The key thing about this is in females, the round ligament is what goes through the inguinal canal. In males, the spermatic cord. So in males, the inguinal canal has wider like holes. You have a superficial and a deep one. In males, it's wider because the spermatic cord is bigger. Round ligament is like smaller, but it's like, this is your round ligament, and then it'll be like going through the inguinal canal. And that should be everything on here. Okay. Next, we have ovaries. So kind of goes with the last topic. They're posterior to the uterus. So This right here, we're looking from behind the uterus. That's why you can see the ovaries. If you can see the ovaries, you're behind the uterus. If you cannot see them, you're looking anterior to the uterus. So we already know it's connected by the mesovarium. And there's also a ligament of the ovary. Right here. Suspensory ligament of the ovary, which will come down. It like suspends this to like the walls. Keeps it in place. So you have an ovarian ligament and a suspensory ligament of the ovary. So yeah, this is one that suspends it is a suspensory. The other two that hold it in its place here are your ovarian ligament, and then you can't see it, but it's the mesovarium that connects it to the uterus. And then it's intraperitoneal, so that's different than retroperitoneal. Retroperitoneal, we said only the anterior part is covered. Intraperitoneal means the entire organ is covered by peritoneum. We talked about mesovarian. The blood supply is obviously going to be ovarian artery. And the ovarian artery actually goes through the suspensory ligament, so this is kind of important. So this is your suspensory ligament, the one we just saw up there. This thing. What's important about this is it actually houses the ovarian artery. So the ovarian artery goes through that. So that's important because if you ever have like if you're trying to remove your ovaries, you also have to cut off the blood supply to them because you don't have them anymore. So you would actually have to cut off this. For drainage, so left ovarian vein will drain into your left renal vein, just like the testicular vein, and then your right will drain into the inferior vena cava. I kind of talked about this in the lab video, but if you think about the way the body is, your abdominal aorta kind of goes down in the middle, but your vena cava is more to the right side, which makes sense because if you think about the heart, your vena cava is here on the right atrium and right ventricle side. So if this is like the middle part of your body, your IVC is more to the right. So usually the stuff on the right will drain right into your IVC. Whereas something from the left, it's kind of a long process to go to the IVC. So it'll drain into a vein, like the renal vein, which will then drain into the IVC. So left ovarian vein goes to the left renal vein, which would then go to the IVC. But the right one just goes directly into the IVC. And then we talked about the ligaments. The ovarian one connects it inferiorly, inferior pole. Suspensory is going to connect the superior pole, as you can see here. And then what's important about the suspensory is the neurovascular bundle because it has the ovarian artery and vein in it. Okay, now, pelvic diaphragm. So this was what we said is like the main support for all of these things. Two main muscles are your coccygeus and your levator ani. She didn't really go into too much specifics or too many specifics with these, so I don't think we have to memorize those. These are the ones she focused on. She said don't worry too much about like the actual muscles that make them up. This is important. It supports the pelvic viscera, and you can see this. So you have your levator ani, which is like all of these. So this and this on each side. Then your coccygeus. So these are going to control, like they're going to hold everything in place on the bottom. This is the one where if something goes wrong here and it's not supporting the way it should, like in females, the uterus could prolapse, like things could like drop down. So this is very important. Now, water under the bridge. This is the thing we talked about earlier when we were talking about Viv, you dangerous dog. We said this is the water under the bridge thing. So uterine artery, ductus deferens in males. Uterine artery in females. The way to remember it is the ureter is always your water. So your water going under the bridge, this is always ureter. This is either uterine, so uterus, or ductus deferens. Uter is uterus, only females. But ureter, we both have a ureter. That's the thing that comes off the renal pelvis, goes all the way down to the posterior bladder. So when you're looking at a picture, this is your ductus deferens going around. And your ureter, if you follow it, going from the kidney all the way down to the bladder. This is the water. This is the bridge going over. Over here, ureter going down to the bladder is your water, uterine artery is the bridge. So ureter, always bridge. The arteries, so uterine artery or ductus deferens are always ureter, always the water, uterine artery or ductus deferens, the other stuff's always the bridge. Now, boundaries for the superficial and deep perineal pouches. I don't know how specific she wants to be with this, but if you think about something that's more superficial, it's more outside, so it's like your external genitalia and muscles. Something deeper is going to be more inside, so like the sphincters that control when you void and when you hold it and whatever. The urogenital diaphragm, the diaphragm inside, the urethra, all these things inside are going to be more deep. So this is how I draw it out to remember it. I don't know if this is going to help, but if you go superficial or superior fascia of the urogenital diaphragm, and then you put inferior fascia of the urogenital diaphragm, and then Colles fascia on the bottom, and then this top, sort of like diamond shape, will get obturator fascia on the side or laterally, and the lower diamond will get ischiopubic rami, or ramus on each side. That will give you your deep pouch, and this would be your superficial pouch. So think of this as like the most superficial. So your deep perineal pouch would be between the superior and inferior fascia, so between here and here, and then laterally it has the obturator fascia. Your superficial pouch would be between the inferior and Colles fascia, so the inferior now is superior to this, and then your lateral is your ischiopubic rami. So what they share is this inferior fascia, or in other words, it's called the perineal membrane. So this is what they both share. That would be inferior to the deep perineal pouch, but superior to the superficial perineal pouch. That makes sense. And then this is a picture that kind of shows the different features in this. I don't know how detailed she wants us to be with this. Some of the key things are in males only, you'll get the bulbourethral glands. And then the urogenital diaphragm, we already said, is in the deep perineal pouch. For the superficial, it's more of like the external stuff. So you're going to get like the outside stuff, so like vagina, your external anal sphincter, anus, ischiocavernosus, bulbous spongiosum, which are like the muscles and all that stuff. The deeper stuff would be like your urogenital diaphragm, urethra, which is like more inside and stuff like that. So I don't know how detailed she wants to be with this, but that's how I remember the borders. Okay, and then the urogenital diaphragm, so it's really just like this upper half right here. We just talked about it, but it has like the deep transverse perineal muscle. It has the sphincter there to help control when you hold it in, when you void, all that stuff. And then it's invested by the superior and inferior fascia, because remember, it's part of the deep perineal pouch, so it's between the superior and inferior fascia. And it supports pelvic organs, has the urethra, all that stuff we just talked about. So this is one of the examples where, like, I don't know how detailed she wants to be about this stuff. She just says define the UG diaphragm. So maybe this is all she wants, but I would also go through the lecture stuff. Okay, next. So these next 2 pages that have like all the lymphatic drainage, I'm gonna save for the lab video, because with stuff like this, if you understand where they're located, what they look like, what arteries supply them, you can understand the drainage. So for example, you have on your abdominal aorta, before it branches off, you have your celiac trunk, superior mesenteric artery, inferior mesenteric artery. Inferior mesenteric artery will have branches for like your descending colon and your sigmoid colon. So it supplies your sigmoid colon. So if your sigmoid colon is going to drain somewhere, it's going to be along the branches of the IMA, or inferior mesenteric artery. When you think of the common iliac artery coming off your abdominal, so we have left and right common iliac, and then that becomes external iliac and internal iliac. We said the internal iliac does like the genital stuff and all the stuff in your pelvis. So when we're talking about bladder, we're talking about internal iliac. We're talking about prostate, internal iliac. Ductus deferens, internal iliac. Seminal vesicles, internal iliac. What else? Your urethra, internal iliac. So knowing where they're located will help you understand which lymph nodes they drain to, because the lymph nodes usually run along like with the arteries and the veins and all that stuff. Once you get like deeper, you'll get like the deep inguinal or superficial inguinal, depending on like which part you're at in the males or females. So once you get like more deep in there, it's not just internal iliac, because that's more higher up, but now you get into like the specific ones. But this will kind of like make more sense with the lab stuff. If you want to just memorize the table, I mean, it's written out very nicely. Anyway, you can memorize it, and then down here, it also breaks it down in a different way. Okay, now, how do the pelvis go into the gluteal region? So, in your pelvis, you have a greater and lesser sciatic foramen. If you look at the names of them, you have a sacrospinous ligament and a sacrotuberous ligament. These two ligaments will create this bigger hole, so greater sciatic foramen, and this lesser hole that goes like through here, which is your lesser sciatic foramen. The names sacrotuberous, sacrospinous tells you they have the same origin, which is sacro, but they connect to something different, which is either spinous, or tuberous. So look at the ischium over here, and you can see this is the ischial spine, this thing that sticks out like a spine. And then this curvy thing is your tuberosity. So the sacrotuberous will connect down to your tuberosity. Your sacrospinous will connect to this spine right here, this spine. Tuberous will be down here. So sacrum to tuberous, sacrotuberous, sacrum to the ischial spine is sacrum spinous. That gives you a greater and a lesser sciatic foramen. The key muscles for greater and lesser sciatic foramen, piriformis is for greater. So the way I remember it is, wow, that's a great performance. So piriformis. Why can I not highlight properly? So piriformis, like great performance, is for your greater sciatic foramen, and then obturator is for your lesser. So the other one would just be for your lesser. They both attach to your greater trochanter. So you can see over here, this right here, going through the greater sciatic foramen, is the piriformis going to the greater trochanter. Obturator internus, this muscle right here, also goes to the greater trochanter. But they go through different foramens. So going through the lesser sciatic foramen, going through the greater sciatic foramen. The other thing about the greater and lesser sciatic foramen are the actual nerves and other contents that go through it. Where is it? I feel like I'm blanking out. Oh, there it is. So you have your piriformis muscle, but you also have your sciatic nerve and then the gluteal vessels. So you can see the sciatic nerve here. Let me highlight them. And then your gluteal muscles and nerves. So you have your inferior gluteal nerve and the superior gluteal nerve. Gluteal vessel, sorry. So those go through the greater sciatic foramen. The lesser sciatic foramen will be the obturator. So if you remember obturator internus muscle, you'll also remember obturator internus. And then remember when we said the internal pudendal was the one that exits the greater sciatic foramen but then enters back. It has that like curvy thing, and then it comes off of the anterior branch of your internal iliac. So here you can see lesser sciatic notch. You can see the pudendal. You see how it like curves like this. And then your obturator internus muscle, obviously. So those are the key things between greater and lesser sciatic foramen. Okay, now pelvic wall. If you look at this pelvic wall, laterally, you have your obturator internus. Posteriorly and superiorly is your piriformis. And then the floor are your big pelvic diaphragm muscles, or your coccygeus and your levator ani. So levator ani is all of this. All of these are your pelvic diaphragm pretty much, so like everything in between here and here. So that makes up the walls of your pelvis. Between the obturator internus and piriformis, we just talked about how piriformis goes through the greater sciatic foramen. Obturator internus goes through the lesser sciatic foramen. They both do the same thing. They both rotate laterally, the thigh laterally, and they hold the femur, the head of the femur, in the acetabulum. Acetabulum is just this like big thing right here in the middle. So your femur will attach to there and then go down into like your leg. They both do the same thing. The only difference is the piriformis also abducts the thigh, so I put that in green. And then for the floor between the coccygeus and the levator ani, they both support the pelvic viscera, so I put that in yellow. The coccygeus will flex the coccyx, so that's another function of it. The levator ani is bigger. It does most of the pelvic diaphragm support, so it's gonna resist any like too much pressure that goes there. Okay, now the perineal pouches, the peritoneal pouches, we talked about this earlier, but in females you have bladder, uterus, rectum. Males, there's no uterus, so males will only have this one right here. So recto-vesical in males. In females, you'll have the recto-uterine and vesico-uterine. So recto-uterine, I don't think she highlighted it too much, so it might not be on here, but there's also a vesico-uterine pouch. The key one, though, is this recto-uterine pouch, which is also called the pouch of Douglas, because this pouch right here, so recto-uterine pouch, is right next to, if you look at this uterus right here, the way it's shaped, it has a like curve right here. This is called a fornix. So there's one there and there's one here. That's the anterior fornix. The one going there where this arrow is pointing is your posterior fornix. So that's the key spot, because that's where you can drain fluids most of the time in females. So if you're going to drain an abscess, you're going to go through the posterior fornix with a syringe, and you drain it from the pouch of Douglas. So that's the more like important part. But actual pouches, there are 2 in females, 1 in males. Okay, different parts of the male urethra. So we have pre-prostatic. So this is not in the urethra yet, but it's still at the bladder neck. Then prostatic goes through the prostate gland. This is the widest and most dilatable part. That's not the longest, though. The longest is the spongy penile part. That's the one where, like, she made a joke. She was like, oh, not in everyone. Haha. The membranous is the narrowest, shortest, and least dilatable. So when you actually look at the pictures, so right here at the neck of the bladder, we haven't gotten into it yet, pre-prostatic. Prostatic literally runs along the prostate. Membranous is going to be the narrowest, least dilatable part right here. And then the spongy is the one that goes all the way and is like the longest part. So those are the 4 parts of the male urethra. This helps bring them down too. So this penile part is the spongy part. Membranous here you can see is the narrowest. And then prostatic literally goes along the prostate. That's your prostate around it. And there's another picture as well here. Okay. Ejaculatory duct is literally just when your ductus deferens and your seminal vesicles join together. So if you zoom in here, your ductus deferens is this big pink thing here. Your seminal vesicles, purple right here, the moment they join together, they form this blue. That's your ejaculatory duct. So I'm going to get rid of this so you can see it. But it's the pink joining in with the purple that forms your ejaculatory duct. So it drains the ductus deferens and the seminal vesicles. The key thing here is into the prostatic urethra. So that's the specific part of the urethra it goes into. So when we were looking at the parts over here, this is where the ductus deferens and seminal vesicles will join together to give you your ejaculatory duct. Okay, now, micturition is literally just urinating. So the way it works is there's a sympathetic part and a parasympathetic part. So when we say sympathetic, we're like fight or flight, all that stuff. Parasympathetic is like rest and digest. That includes like urination. You're voiding. So parasympathetic is going to be the actual voiding, but the storing part is sympathetic. So think of when you are filling up fluid or urine in your bladder. Your bladder needs to first expand to then void. Your bladder has a bunch of muscles or a big muscle around it called a detrusor muscle. Where's that? Right here. Your detrusor muscle. So that senses when your bladder is like expanding. So when your bladder starts to fill, that's when the sympathetic nerves are activated. It has to relax the muscle so that it could expand and fill with urine or fluid or whatever's in there at that time. It will contract or close the internal urethral sphincter. So think about it. Your internal urethral sphincter is this thing right here. If we don't want to void, but we want to hold it in, this bladder will expand, but we don't want anything leaking out, so we'll close this. That is the sympathetic response. It's storing it in. The parasympathetic would then be the opposite. Parasympathetic is going to be to contract the detrusor muscle. So now we want to push it back in, make it narrower, and then we're going to open this so urine can flow out. So when the bladder is filling, the stretch receptor, this is involuntary. You don't tell your bladder, hey, start filling up, right? But you can control one like you void or not. We said sympathetic, bladder fills, So your detruser is relaxed because it's getting bigger, it's storing it, and will close the internal urethral sphincter so you don't leak. Then, when it gets to a point where it's too distended, the sensation will acknowledge the sympathetic activity, and then it'll be inhibited by the parasympathetic. So now we'll get the opposite. Now your detrusal will contract, your internal sphincter will relax or open so that we can void the urine. So sympathetic, we're storing. Detruser muscle is going to expand. Internal is going to close. Parasympathetic, we want to void. So now the detrusers are going to contract, and the internal is going to open. That's literally all it is. Between males and females, so really quickly, actually, okay. Between males and females, males will have, the urethra will have double duty. So it's not just for urination, but it's also for ejaculation. And then for the pudendal nerve, that's the nerve we were talking about that does like all like the important stuff within your genitals. So that actually is the one that controls the external urethral sphincter. So that allows for voluntary holding or initiation of urination. So when you can kind of control when you urinate and when you try to like hold it in more, and that has to do with the pudendal nerve. So if this nerve was damaged, then you would just be urinating without having that control. And then lastly, the autonomic nerve. Oh, before that, the urethra in females is much shorter. That's why they're at higher risk for UTIs. But that also makes it like easier to treat UTIs because it's a quick route. And then lastly, autonomic nervous system overreaction, the easiest thing. Point, P parasympathetic, S shoot, S sympathetic. When we're talking about parasympathetic, it's S2 to S4 because that's your pelvic splanchnic. I might have forgotten to mention them here. Yep, so pelvic splanchnic. Anytime parasympathetic, pelvic splanchnic. Sorry for all the scribbling, whatever. But pelvic splanchnic are the only splanchnics that are parasympathetic, are your pelvic splanchnic. So the pointing or the actual erection part is parasympathetic. But the shooting, when you contract it so that you can open it up and let the fluids out, is sympathetic. So that's the key difference. If we're talking about parasympathetic, we're talking about S2 to S4. If we're talking about sympathetic, it's going to be like the lumbar nerves or L1 to L2. So P, point, parasympathetic, S, shoot, sympathetic. And then the actual muscle that's contracted is your bulbospongiosus during ejaculation. So you contract your internal urethral sphincter. The reason for this is you want to prevent retrograde ejaculation. So that's important. You don't want it to go back up. You want it to go out. Obviously, if there's damage here with this process, with these nerves, then you will have retrograde ejaculation. And that should be everything for exam 1 study guide. Sorry if I kind of like flew through this. But yeah, thank you, Paulina, again. This study guide is incredible. And I hope you guys enjoyed this, learned something from it. I will definitely still go over her 2 lectures. And then embryo will also be added to the end of this. Paulina also did the embryo part. So thank you again. And I hope you guys have a great day.